Hello. Thank you for coming to the presentation of What is Obesity Medicine? An introduction to the field of obesity medicine. Our objectives for this presentation is to help better define what obesity medicine is, how to diagnose obesity beyond BMI, looking at the challenges and opportunities in this field that is emerging in obesity medicine, as well as some trends and history of how obesity medicine was and is now evolving into a new frontier. The field of medicine dedicated to the comprehensive care of patients with obesity is obesity medicine. Classic and traditional methods for defining of obesity have been BMI, or body mass index, which is where one's individual weight in kilograms over their height over meter squared gives them a number that puts them in a classification of either underweight, healthy weight, overweight, or class 1, 2, or 3 obesity. While BMI is an effective screening and epidemiologic tool, it certainly has its limitations, such as doesn't take into consideration gender differences, racial or ethnicity differences, or body type differences, such as a person with a more muscular build or less muscular build. And what's important in using BMI as a screen is determining whether or not an individual is at risk for other disease states that would potentially impair their health. So, put another way, is the abnormal function or excessive fat accumulation or adiposity in the body potentially impairing the health of this individual? One way to take BMI a step further is utilizing a staging system called the Edmonton Obesity Staging System for assessing risk. The staging system utilizes different stages, assessing the potential medical, psychological, and functional disabilities an individual may be struggling with as either a part of their weight, a result of their weight, or caused by their weight. So for instance, a stage 0 would be an individual whose weight does not have any obesity-related risk factors. But a stage 1, an individual's blood pressure might be borderline. Their blood sugars or diabetes might be a consideration, or pre-diabetes. They're starting to struggle with some minor aches and pains as they use the stairs or try to exercise. And they might be experiencing some mild stress from their weight. A stage 2 would be where obesity-related diseases are already there, such as hypertension, polycystic ovarian syndrome, or diabetes. And this individual will be talking about their moderate limitations of activities of daily living. For instance, difficulty walking to the mailbox or utilizing the stairs, experiencing shortness of breath or aches and pains when they try to attempt activity. Stage 3 and 4 is a more severe progression of the disease, where an individual may have already established end organ damage, such as a myocardial infarction or congestive heart failure, and significant severe disabilities that may require wheelchair use or loss of ambulation capacity. And why is this important? Because when we're looking beyond BMI, when we're trying to find a way to determine whether or not weight could be causing decreased survivability or increased mortality, the Edmonton Obesity Staging System can help better determine, beyond BMI, an individual's risk for mortality. So is obesity really a disease? There are some individuals that agree with this. There are many organizations that also agree with this. Yet there are still people and other organizations that may have some concern or do not quite believe that obesity is a disease. However, it's becoming more officially recognized as a disease, such as these organizations, Obesity Medicine Association, the Obesity Society, the American Medical Association, and the World Health Organization, who fully stand by the fact that obesity is a disease. Appetite regulation is complex. Any individual who struggles with weight would be able to tell you that. The discovery of leptin seems to be a turning point in the thinking in the medical profession, where understanding obesity as a chronic disease is related to the science of understanding complex appetite regulation. These complexities with appetite is further elucidated by individuals who struggle with their choices of food and are struggling with conditions such as hypothalamic injury of the CNS, insulin resistance, and leptin resistance. These individuals, their brains can't tell how much fat is stored or how much food is eaten. This results in an increased cravings and a reduced sense of feeling full or satiety, which ultimately leads to increased food intake and weight gain. The weight gain further compounds the resistance to leptin and insulin and increases those cravings. Essentially, a feed-forward positive feedback mechanism, or otherwise known as a vicious cycle. Obesity is a disease, and obesity prevalence is getting worse and worse. If you look at the data of prevalence of obesity from the 1980s onward, you will see a dramatic progression in states who have more and more individuals struggling with this disease. As of 2015, no state has a prevalence of obesity less than 20% in our country. And more states have a prevalence of obesity of greater than 35%. Why this is important is when you look at the trends of how many individuals are struggling with obesity, there's been a significant increase in the prevalence over the past 30 years. And when you look at what the projections will be for 2030, over 50% of individuals in the United States, ages 20 to 74, will have a BMI of 30 or higher. If you take into consideration a BMI of 25 or higher, there will be over 85% of individuals with that diagnosis. That is a significant amount of individuals that are struggling with weight in our country. Yet, obesity remains underdiagnosed in the United States. This data here is from the GE Centricity electronic health records, which essentially looked at over 6 million individuals. The idea was to assess the prevalence of chronic disease states such as diabetes, high blood pressure, hyperlipidemia, and whether or not BMI had a role in affecting disease progression. But what was remarkable was how few individuals were diagnosed in the electronic health record with a BMI code or an obesity code. Very few individuals are being diagnosed with obesity. And what is the economic burden in our country? Direct medical costs, or U.S. healthcare spending, is anywhere from 21 to 28% of our total U.S. spending. And what about the indirect non-medical costs? Cost of the employer, lost productivity, absenteeism. Overall cost of obesity is up to $500 billion a year. However, reducing our weight, reducing our BMI, reducing our weight by a 5 to 10% clinically significant weight loss, which has been understood in the medical and scientific communities to be clinically significant weight loss, can result in an estimated reduction of annual cost per individual of up to $20,000. And this is reducing the costs through medications, reduced copays, doctor visits, and hospitalizations, reduced risk for cancer, accidents, and food costs. The good news is that 5% average BMI reduction in the United States, if we're able to accomplish that by 2020, will reduce 3.5 million cases of hypertension, avoid 2.9 million cases of heart disease and stroke, avoid 3.6 million cases of diabetes and 1.9 million cases of arthritis. So if treating obesity reduces the risk of so many health conditions and healthcare costs, why do so few healthcare providers diagnose and treat obesity? In the past, very few patients were offered medical or surgical treatment. However, we now have tools that we can use both medically and surgically, in addition to lifestyle, to help better get our patients access to the care and treatment that they so need and deserve. There are many potential barriers in treating obesity: provider reimbursement, limited prescription coverage, past failures both for clinician as well as for patient, lack of clear guidelines, time constraints in the office, as well as cultural stigma and bias. And it's hard to believe that it was actually considered fraud to bill for obesity-related services prior to 2012, but we have come a long way. And since then, we've made great strides in the field of obesity medicine in being able to provide patients with access to care and treatment. Addressing weight bias is very important for us as clinicians as well as for our patients. Negative attitudes towards individuals who struggle with weight leads to rejection, prejudice, discrimination, bullying, and this comes in various forms, both subtle as well as overt. But what it really does is prevents the proper care and communication between providers as well as their patients. It hampers our efforts to be able to effectively combat this epidemic, and it unfortunately reduces our ability to give patients the proper access and treatment that they need. Recognizing this, helping combat this, will only help our patients get better. In fact, they did a survey of over 2,400 women, and they were asked, well, how do you cope with stigma or bias? Do you feel that you are judged? And almost 80% reported that yes, they do, and that eating, turning to food, was a coping mechanism, further compounding the problems that our individuals face. So what might comprehensive medical obesity treatment include? That would look like nutritional counseling, physical activity, changing behaviors to a positive way and positive lifestyle, as well as considering pharmacotherapy when indicated. This field is growing. By 2015, there's been over 36,000 newly certified physicians by the American Board of Internal Medicine, and new subspecialties are emerging, such as adolescent medicine, geriatric medicine, and addiction medicine. Obesity medicine is no different. The American Board of Obesity Medicine was created in 2011 and has more than 2,000 diplomats as of 2017. The growth of this group is faster than any other field. Obesity medicine is at its frontier. The number of diplomats from 2012 to 2017 ever continues to grow. There's great resources out there for your patients as well as for you. There are many organizations that helped support the production of this presentation and are available for both you and your patients, and giving your patients the best access to care that they most certainly deserve. Thank you for your time.